angle closure glaucoma is estimated to affect 15 million people worldwide. It is responsible for 50% of glaucoma blindness. It results from apposition or adhesion of the peripheral iris to the surface of the pigmented trabeculum. The blocking of aqueous access to the trabeculum results in raised intraocular pressure. Acute angle closure glaucoma. It is a true ophthalmic emergency, and a delay in treatment can result in blindness. It accounts for a significant number of glaucoma cases among persons of Eastern Asian and Southeast Asian descent. Some investigators reported beneficial effects of a procedure called goniosynechialysis combined with phacoemulsification to widen the anterior chamber angle, especially in cases of acute primary angle closure with recently formed peripheral anterior synechia. Goniosynechialysis physically separates peripheral anterior synechia (PAS) from the trabecular meshwork using a spatula or microforceps under direct visualization with a gonio lens. So, what exactly is phaco plus? In this procedure, goniosynechialysis is combined with phacoemulsification to widen the anterior chamber angle, along with inadvertent goniotomy with the help of Tonito microhook. Indications include acute primary angle closure, acute on chronic angle closure, primary angle closure, and PACG controlled with medication. The Tonito microhook used for trabeculotomy is a reusable, slender, Sinskey hook-like instrument that comes as straight, left, and right hooks. Surgery in acute angle closure is ridden with challenges, ranging from residual corneal edema, poor dilatation, large lens, weak zonules to floppy iris. We present a case of 70-year-old female who presented with headache and was treated at a local hospital for raised IOP. Examination revealed corneal epithelial edema with fixed, dilated pupil and an IOP of 54 mm mercury in left eye. Patient underwent peripheral iridotomy in both eyes, and IOP came down to 25 mm mercury. The lens was thick in both eyes with 5.10 mm in left eye. Patient was planned for phaco plus. Precautions needs to be taken while performing phaco. Adequate dilatation was obtained using high-density viscoelastics. Hydro procedures need to be gentle. Here a hydrodelineation along with dissection is being done. Perform phacoemulsification using lower parameters to ensure safety. Here a direct chop is being done. Intraocular lens is implanted in the bag. After docking the gonulens, the angle is visualized and goniosynechialysis is done. The peripheral anterior synechia is released gently using Tonito microhook. Then cleavage of the trabecular meshwork is done using Tonito microhook. Trabeculotomy is done in other quadrants as well. Post-op medications included topical steroids, antibiotics, and pilocarpine. At 2 weeks post-op, patient had a vision of 6x6 and IOP of 11 mm mercury. Next patient is a 65-year-old female who had undergone peripheral iridotomy in both eyes. Examination revealed an IOP of 26 mm mercury with grade 4 cataract. Both eyes had short axial length. Central fields were constricted. Patient was planned for phaco plus. In this case, iris hooks were used for obtaining adequate mydriasis. Phacoemulsification was performed with care. A multi-piece intraocular lens was implanted in the bag. This was followed by goniosynechialysis and trabeculotomy using Tonito microhook to complete the phacoplus. At post-op 2 weeks, patient had an IOP of 18 mm mercury without medications. So what is the optimal timing of cataract extraction after an acute attack? 4 to 6 weeks after control is suggested to minimize risks. Studies show that IOP and medications after acute attack can be reduced by phacoemulsification, and lowering of IOP was found to correlate with lens thickness. Also, phacoemulsification combined with goniosynechiolysis was effective in both acute and chronic angle closure glaucoma. However, reformation of peripheral anterior synechiae was common in chronic cases. Prerequisites for Phaco Plus include Swan-Jacob gonulins, Tonito microhook. Keep phaco parameters low. High-density viscoelastics should be used for docking and maintaining the anterior chamber. The authors have no financial interests in the products shown. There are multiple mechanisms for IOP reduction. It can be due to improved outflow due to deepening of anterior chamber, phacoemulsification-induced stress remodeling from ultrasonic vibration, surgical trauma-induced prostaglandin release, which increased uveoscleral outflow, and high fluidics during phacoforces fluid through the trabecular meshwork into the canal of Schlemm, which may increase patency and promote flow. Thus, the technique of PhacoPlus deepens the anterior chamber, eliminates pupillary block, and reopens the natural aqueous pathway. The advantages include early visual recovery, good near vision, and avoiding complications of trabeculectomy. This simple technique is a boon to surgeons and patients, like the sunshine through the dense forest.